Hello and welcome to Thanatology Themes. This is your host, Carolyn, therapist and thanatologist. I'm really excited today. We have a really great guest who's joining us. And Patti, I hope I pronounce your last name correctly. Patti Anewalt?
Uh-huh. Yep.
Yay, okay.
Okay.
So Patty is going to talk to us today about intimacy and sexuality during illness and loss, which I think is kind of a new, very important, but a new topic in hospice and end of life care. So this is really exciting. So Patty, I'm going to go ahead and read your bio, your very impressive bio. Is that okay?
Sure. I didn't know you had it.
So Patty, you're a PhD, LPC, and FT. And I'll talk, Patty's an FT. I just got my FT last December. I think you've had yours quite a long time, right?
I have, yep.
So Patty is the founder and former director of Hospice and Community Care's Pathways Center for Grief and Loss. The focus of her clinical practice, writing, and teaching is on issues related to end of life, grief, compassion fatigue, and crisis response, presenting at the international, national, and local level. Patty works part-time now at the Pathways Center and also writes articles for Hospice Foundation of America's Journeys newsletter. And we've talked about Hospice Foundation of America on other episodes. She is recognized as a fellow in thanatology, yay! With the Association for Death Education and Counseling. Big fan, we talk about that a lot, and is an active member of the International Work Group on Death, Dying, and Bereavement. The Pathways Center for Grief and Loss offers the most comprehensive variety of bereavement services for adults, children, and teens in South Central Pennsylvania, serving close to 9,000 bereaved individuals annually. Wow. So thank you, Patty, so much for being here.
Oh, it's a pleasure to be here. Thank you.
Wow. I have so many questions I want to ask you, but I know we need to stay focused on the topic. But can I briefly ask you, when did you get your fellowship, fellow in thanatology?
I honestly don't remember it was that long ago. It's been a good dozen years or more. In fact, when I got my FT, the president of our organization wrote me a very nice handwritten note, said congratulations on your fellowship in thanatology, whatever that means, which I thought was pretty funny. But he's a CPA and he's our president. So it's not his area to know that, although I kind of thought he should. So yeah.
A friend of mine, I posted it on LinkedIn when I got mine, and a friend was like, congratulations. And you got me to look up the word thanatology.
That's good.
Well, that's really cool. I could do a whole podcast on that because I'm a big I'm really excited about ADEC and the fellow. But I'm gonna focus and intimacy and sexuality during illness and loss. So, I worked in hospice for a number of years, and I'm jumping ahead here, but this never came up. This was never addressed. I feel like you're really doing some like cutting edge work here. Do you want to just address that?
Sure. I would like to because it it's it's really not a new concept, but it is something that's never talked about. And I was aware I've been in my hospice for 30 years. And when we were smaller, I oversaw spiritual care, social work, and bereavement. So I was pretty tuned into the counseling perspectives aspect of hospice, and yet it had never come up. So I thought and realized we should be talking about it because honestly, actually from the National Hospice and Palliative Care Organization, a core competency for social workers in end-of-life settings is to be evaluating their sexuality. When you think about it, it's such an important quality of life indicator, and yet nobody was talking about it. If we say that we're assessing the difference between hospice care and any other medical care that we in the United States, is that we say it doesn't just cover the medical aspect, it's all the holistic aspect of an individual. Well, if it is the holistic aspect of an individual, the psychosocial, emotional, spiritual, then a core component of that should be people's sexuality and intimacy and how that is impacted by illness and loss. So that was it's not as though I have a wealth of experience myself with all this either. It was more the realization that I felt I needed to bring this up as a topic to address in our hospice. And I'm happy to say, actually, in having done so, somewhere here, I jotted down my note on a couple different examples. After we trained, I did a session. It was kind of like a 101 about this topic. I knew we wouldn't cover everything in an hour and a half that we had with our staff. But coming away from that, I heard later that there was a young man, I'm 70, he was 50 something, a patient in our inpatient center, and was married. And when the staff were discussing or reviewing his case and his situation, a couple people had been to my talk, and so they said, maybe we do need to talk with them and ask them if they have any concerns, this couple. He was, facing end of life care, and he had a wife, and maybe we need to discuss this with, who would feel most comfortable bringing this up with the patient. So that was one example. Another example was literally a day after the training that I did to kind of just bring out this topic. A nurse had gone out to the home of a hospice patient who was in his 50s, and she was rather concerned about him because when she first arrived there, he was kind of red in his face and short of breath, and seemed to be breathing harder. And so she asked him, "What's going on? I want to take your blood pressure," or something like that. And he was a single man, but he had a girlfriend, and he looked at the nurse and he kind of hinted around and said, "Well, my girlfriend just left." And the nurse got all bothered and upset and shut down and said, "Oh," and kind of implied that, some fun was going on, and but she didn't want to talk about it. She talked about it when she got back to the hospice and said, "I couldn't talk about that." Obviously she hadn't been to my training. So, it gave an opportunity for that team leader to kind of have that conversation with her as well. So those are the kinds of things that at least it started people thinking about it, which was
It's
my goal.
No, I agree. I even have a video about the biopsychosocial spiritual, and now we need to add the sexual. Oh, and in hospice, we also do a financial, right?
Right.
Biopsychosocial, spiritual, financial, and the sexual, maybe we open up this conversation. And I agree with you. This is the social worker does the assessment, and then we pull in and everybody that can be a part of this and work with our team. I am just so impressed because I feel like this was just something, we never talked about and never, and when I say we, I'm talking about the clinicians, right? We never
Right.
brought this up. So this is amazing. And I agree with you. This is a real holistic approach,
Well,
right?
and I did encounter after I've done these trainings, I did also find an article, because of course now whenever I see this anywhere, I click on it and read further. And this was an article that talked about where it was I don't know, topic was sexual function and serious illness with a few physicians. And what they said was that clinicians can get caught in an anxiety cycle in
Mm,
which they're afraid to ask, they don't ask, then they have increased anxiety about not asking. And it went on to say that, like any other conversation, you have to start, and through experience, you kind of learn what language is comfortable to you. They talk about the importance of using plain language and normalizing sexual health questions, such as, like, many of my patients experience issues with intimacy and sexual health because of their illness. How has this been for you? I mean, that's a very basic way of asking that question, and the patient will make it very clear whether they want to talk about it or not. Hopefully in our session today, we can, go over some of the examples that I used to kind of illustrate how to bring up those questions.
yes, that's wonderful. And I do want to say, I know your presentation is for clinicians, hospice workers. And I think this is also just important for the general public to know, hey, we do want to open up these conversations to you. We do understand that this might be important at all times of life, but certainly at this time as well, right?
Right. And one of the handouts that I did use, that I got permission from Carrie Arnold, who is also a member of ADEC, and she wrote for their companion. I got this idea from the HFA's teleconference that they did on this topic, and that's kind of what sparked the idea for me. And so I obtained permission from her, and I made a handout about the similarities in talking about death and talking about sex. And part of my point to the hospice staff was, 95%, I'd say, of staff that we have working in hospice come to us from other walks of life, hospitals, or churches for pastors or whatever, social workers from all kinds of other helpful professions, but none of them have had hospice experience until they are trained by our hospice. So none of them are particularly comfortable with talking about death and dying initially, but they figure out how to get comfortable with it as time goes on. And in the same way, most people are not very comfortable talking about sex, but it can get more comfortable as you start to incorporate it, make it a priority in your practice.
So I love this. I thought this was so great. And this is a really great place for us to start. Similarities in talking about death and sex. You wrote a number of things here. I thought they were all fantastic. Are there a few you want to share or you think might be particularly helpful, or these are,
Um,
yeah.
well, yeah, I mean, kind of separating out mortality and sexuality. There's so many metaphors for when people die. People say passed away. They often don't say died. They can say, there's that song, another one, bites the dust, biting the dust. I mean, there's all kinds of, casual phrases for that, as opposed to using the word died, which is a much more direct way. I remember when I was raising my kids, my mother never wanted me to say penis or vagina with my young daughter and young son, and she got upset every time I did. That's an example of her discomfort with that. But in sexuality, they're talking about getting it on, getting some, being frisky. I mean, these are all the funny words to kind of avoid talking directly about it. So I'm trying to think what other well, even think about education. There's not a lot of education about death and dying with schools, or teaching children about death and dying either. And similarly, even in medical fields, and the fact that we're only now bringing this up as a topic, it's just not usually included when we talk about sexuality. So there's just so many different aspects. I mean, holistic in nature is an example where there's death and dying and loss all around us, and yet we tend to not even think about it, and it impacts our entire life, and yet we often try to block it out. And sexuality, as we've just talked about, is such an important component of our physical, emotional, psychological, and spiritual well-being. So yeah, it just goes on. And my point with the staff is I didn't want them to get wigged out as I bring up this topic. I wanted to help them go back to remember how you were when you first started in hospice. You were not very comfortable with this whole death and dying thing, but you were giving it a shot. And in the same regard, this comfort level would come with practice.
Yeah, that's amazing. And I just want to jump in with the two that I also thought were really important: cultural, societal, and religious influences. I thought that was very, mortality deeply, these things deeply influence death systems, and they also can really influence our understanding of sexuality,
Well, and
right?
a great example of that, when I was doing the training, there was only one social worker. We've got like 25 social workers at least in our hospice. There was one who was my champion, who egged me on with this and said, yes, we need to do this. She's totally comfortable bringing it up. And so she gave the example during my training of an older Amish couple that she was visiting with in their home. So when we talk about cultural perspective, I mean, what I learned from my staff as I asked questions ahead of time is they all presume living in Lancaster County with a lot of Amish and a very culturally rather, what's the word, conservative community. They wouldn't want to talk about it. And so when she did bring it up with this Amish couple, and they very much wanted to talk about the effect that the illness was having on their on their levels of intimacy as well as sexuality. So that taught her, she said, from that time on, she has always brought it up. So we don't want to make our own judgments based on our own cultural biases. That's very important.
Okay, that's an amazing example. Wow, that's really, really important. Okay. And then the last one the other one I just thought was the limited understanding, death denial is pervasive in Western culture, despite being a theme in popular culture. And I think in sexuality, it's very similar too, right? We don't have these direct, honest conversations, but then it'll be, in a movie or something.
Right, exactly. Very much so.
So I thought those were really, I thought that was a really, really great place to start. Um, so now can we move into the PowerPoint that you had created for the clinicians?
Sure.
Um, so I also, it sounds like in the beginning, though, I know that you went through the phases of life-threatening illness. Was that to just kind of give the clinicians just a review of that?
Well, I think that was Ken Doka's phases of different life-threatening illness, and my point in having that slide up with the staff was to explain that we are in hospice care. Unfortunately, we get people far too late in their disease process, but the focus of the conversation for the training was going to be on facing end of life and terminal illness, and then after a loss. But that is to say, the moment somebody has a diagnosis as starting any kind of treatment with some kind of illness, it will affect them intimacy wise, sexuality wise, psychologically, so well, emotionally, spiritually. So they're going through so much of this, and it's going to impact their if they have an active sex life, it's probably going to, I assume it would impact that, and we need to ask about that to find out where they are with that. So I was talking about how for the purposes of this, it was really going to focus on end of life and bereavement.
Hmm. But you bring up a good point about, as soon as someone gets the diagnosis, this and now that I'm in private practice, sometimes I'll have people who are grieving and they'll say, we didn't have sex for the whole year before the person died, right?
Right, right.
Yeah, so just, that's just being aware of that piece too. Just
Well, and healthcare professionals have said that if patients had concerns in sexuality, the professional assumes that the patient will bring that up. Whereas most patients, the research shows that most patients reported that despite wanting to talk about it and have that opportunity, their healthcare professional never approaches the topic. So in essence, if I could summarize in one sentence, what we're talking about this whole hour, and the reason why I did this presentation was that point, that most people professionally err on the side that, well, the patient will bring it up if they care about it. And what I'm saying, and the research proves, is the patients desperately want to care about it, even if they don't have a partner and don't have any interest in intimacy or sexuality at the moment, when it's still important for the professional to bring that up as part of their comprehensive assessment.
Mhm. Yeah, that's our holistic approach, right?
Yeah, exactly.
So, will you define for us the terms intimacy, sex, and sexuality?
Yes, I'm looking for my notes, so I say it better than what I had on my notes here. I had separated that out to make sure I had it handy. Again, for the purposes of this session, we were limiting it to primarily to sexuality. When we're talking about intimacy, there can be all kinds of intimacy. Most of us have very intimate relationships with friends of the same sex, friends of the other sex that have nothing to do with sex. We can feel very, very close to somebody. For the purpose of the training that I did, I was limiting the intimacy to the context of sexual intimacy. So intimacy is really any deep personal relationship with a partner that conveys that emotional closeness, and hopefully, if it's an intimate sexual partner, there's previous sexual intimacy where their personal space is not impinged upon. They feel close without any discomfort. um, so any kind of, trust, interdependence, caring, commitment, mutual responsiveness. I mean, we all have many relationships that experience this, and usually they're much more narrow when it comes to sexual intimacy. So sexual intimacy really can, in having sexual intimacy, it really can lessen depression. It can distract from pain. When you think about patients who are very sick, it can really minimize muscular tension, sexual activity can release oxytocin, and that's a natural antidepressant. And when you think about all the patients go through when they have a serious illness, that's so important. So sexuality, sex is actually the physical activity between two people. They're touching each other in the intimate sexual areas, and it may or may not include sexual intercourse. And sexuality is really encompasses all the behaviors and attitudes that influence our sexual orientation, and how we express it. It's how we feel sexually, what our thoughts are, what our attractions are. So, so I think a lot of times as patients are very ill, when we're talking about serious illness, there still can be a lot of intimacy. There may or may not be sexual intimacy, but there's still a lot of intimacy with people that have partners that have had sexual intimacy. Sometimes, we need to have that conversation. Maybe they just don't want to. They're not interested in sexual intimacy at the moment, but they are interested in being touched and held and feeling close with their partner, even though they're not interested in sex. But we don't know that unless we ask. That's my main point.
Yeah, I think that's a really, and you bring up so many important points here. And I think that intimacy piece, I mean, all of the pieces are really important. So I think that was really succinct and helpful. And that continuing to be close to someone and continuing that part of the relationship, as you're saying, is so supportive for people. And I was thinking, certainly the patients, but as you know, hospice social workers do so much work with the caregivers too, right?
Exactly, exactly. And sometimes you might ask the caregiver, it just, we only know until we're working with that family and we have a sense of where to go and what to do. I mean, there's a lot of, there's a whole art to this. It's not a black and white rules that we follow. We really have to figure out who to approach and how to go about it and all that kind of stuff.
Just for a minute, I know you had a slide that it affects the family system. Can you just briefly touch on that?
Sure. Yeah. Well, we put that on in there actually because during the few months that Jill and I were preparing this to train hospice staff, we really, Jill herself was going through with her husband's family. His mother was dying, and so we're preparing this, and she's saying, "Let me tell you, Patty, it's affecting our sexual intimacy." I mean, because the point being, um, you know, when you're tired and you're exhausting and you're working full time and then you're traveling away to out of state to go to a family loved one, there's a ripple effect that affects all relationships in the family. So, things can be tenser at home and tensions can be high. So we want to make sure and be aware of our own biases, our own assumptions when it comes to what is a family and who is affected and how are they affected. And that's the beauty of hospice, is that we say it's not just it's the patient and the family and the caregivers, and whoever is impacted by this illness is part of who we need to kind of check in with and provide support to.
Yeah, I mean, one of the ways I also used to describe it when when a new patient and family would come on to our hospice program, I would often say to the caregiver, to the family, I say, I'm also here myself and the spiritual care counselor. I support the person that supports the patient.
Mm-hmm. And there are so many stressors with serious illness and role changes that really can get in the way of sexuality and sexual intimacy because so much is happening and so much is changing.
Yeah. Yeah. Okay. No, thank you. So moving on, I'm not sure if this is something we'll want to talk about, but you had written self-reflection and guided imagery, and I love guided imagery, so I was curious what that part was.
Sure. Yeah, I had asked one of our hospice social workers that had been a hospice social worker and a team leader, and she'd been in hospice, gosh, more than 20 years as I had. So she and she also has training in MBSR, so she, mindfulness and stress and all that stuff. So anyway, I asked her to kind of step us through and create a guided imagery where basically at the beginning of the session that we met with hospice staff, we had them close their eyes if they were comfortable doing that. And we basically stepped them through going to the doctor. It's a normal work day. You know, you run to the doctor after work for your physical, and then they discover something, and we were very vague about what it was. So we let people kind of envision their own kind of greatest fear about, if they had a diagnosis that was serious illness. So, but then you get this diagnosis and they do further tests. And so the imagery kind of stepped them through how kind of fast forward of several months of illness that progressed. And during that imagery, we would pause and say, where would you be now? Would you want to be by yourself? Would you want to pull your favorite fur, what does she call them? Fur bodies or something like that, like a stuffed, not a stuffed animal, a real animal, if you have a dog or whatever, or, is there an intimate partner that you would want to be with, or would you want to be by yourself? I mean, we step them through what they would need, and literally right towards the end where they're very ill and nearing end of life, again, pausing again, where are you with this? Do you want to be, hold hands with somebody else? Do you want them with you? Do you want them in bed with you? Do you want to be by yourself? That kind of thing. The point being, we wanted people to face and come to terms with and have a sense of how would it be for them personally, because that's the lens that they're looking through as they're working with patients and families. And so we need to be very clear about what are our needs and keep them separate from, be aware that that's our needs. That may or may not be the needs of the people that you're working with. And I just think it's so critical to be able to be aware of that, because there may be a certain case in a certain patient situation that might hit too close to home with maybe your greatest fear that could happen to you. And you may not be handling that appropriately because it's so tapping into your own needs. So we started the session with that early on, because we felt that was very important to look at first before we delved into, okay, now how should we be addressing this with patients and families?
Wow. And so that is so interesting. I have done a death meditation, Buddhist perspective, and you go through the whole you see yourself dying and this kind of thing. But I hear this lens that you really added onto it, do you want to be by yourself and your fur babies? I know people use that
Yeah,
term.
that's it, fur baby. Yeah, I don't use that term, but she used it, and it, and she does have a fur baby, and it was a good reminder to me that, that might be it for somebody.
Oh yeah, I remember I had a client who had a cat, stayed with her the entire time. I mean, the cat did not leave this person's side.
Mm.
Or, but I love this lens, holding hands, or who do you want with you, or someone in bed with, this whole act
Uh-huh.
of this, what I'm going to call a dying meditation. Because I think nowadays I mean, I do think this is really helpful for clinicians also, in general, maybe to do.
Right. Exactly. Yeah.
And you really added that extra lens of that intimacy or embodied piece of it.
Hmm.
Great. Okay. So I thought we might jump ahead to the sexual assessment. I just thought that that seemed really important.
Well, can I jump in for a second to say, in talking about that, part of what we need to recognize and name that I learned when I talked with our own hospice staff, but then in addition to that, I was floored when I took copious notes as I talked to many different staff about kind of what their hangups were and what they do and don't do. And then when I read the book, the companion book, the HFA book on this topic, I was floored to realize that every single one of the obstacles that I identified were in the book. I mean, people feel like the answers I got were, when you talk about sexual assessment, we got to scroll back for a minute. First of all, people feel like they don't have any training in this. Inadequate clinical training. It wasn't covered in our orientation or any of our training. There's too many other things I need to do or get to. I don't have enough time to bring up something on this level because there's so many other priorities. All of them talked about how, well, if the patient's not bringing it up, I'm not going to bring it up. So there was that concern about being unnecessarily intrusive. And I think underestimating the significance of intimacy and sexuality. And assuming that the patient will bring it up if the discussion is important. So, or assuming that because they're, they're old or their health status, or they don't have a partner or whatever, they're making those assumptions and based on that, not bringing it up. So all those obstacles will interfere with people's ability to even consider a sexual assessment. So I just wanted to add that into, when we jump into the sexual assessment component.
I think that's true. And I do think that, right, we think they're too old. We do bring all of these things in. And I do think that hospice social workers, but hospice staff in general, I feel, do try to be aware of their biases, or we do trainings, or
Right.
we talk about it. This isn't a new idea, but when it comes to sexuality, it is kind of a new idea. I think
Because
this is,
it's never talked about. Yeah.
yeah. It's the one place where I think a lot of us haven't really, like you said, had a training, had a, converse, all of these things, right?
Yep.
Yeah,
But when
okay.
it comes to sexual assessment, I mean, there's such a wide range of ways to kind of bring it up, and there's so many aspects to, when you consider how you assess for sexuality and what the priority is. I mean, even just asking how important has a sex life been to the patient would be a starting question. Just I think bringing up in the beginning, I think in an initial, this earlier you can bring this up, the better. If it seems to fit, obviously you want to develop a relationship and a rapport with the patient or the family member. And usually it would be the sexual assessment would be with the patient, but you've developed that rapport initially. But usually the social worker is supposed to do a comprehensive assessment somewhere fairly early on in working with the patient. And a component of that would be just some questions about, how important has, your sex life with your husband been? Do you have a sex life with your spouse? If not, is that a concern for you? How has that changed with this diagnosis? It should just be an integral part of the rest of the psychosocial assessment that's going on. And then from there, kind of judging, using those counseling skills to assess the comfort level. Is this an area you're comfortable talking about? um I'm comfortable with it, but I want to know, I certainly don't want to bring things up that you're not comfortable talking about. So you'll gauge and get a sense from the beginning how far to go or how much you might be comfortable asking based on their comfort level. Does that make sense?
Absolutely. I think social workers, right, we do have the skill set. I remember, one of the first things I learned in social work school is it's a conversation, not an interview, right? So
Right.
have the training, this is just a new topic,
Right.
right? Um,
Exactly.
So, opening, and I also hear what you're saying. I think part of it is even just being open to it. How has your sex life been? Is this a concern? Is it something to talk about?
Right.
And like you said, we'll see where they go from there. For
Right.
sure.
Exactly.
And the
And
other,
it can be very in depth if the person, is very interested in talking about it. There's a whole gamut of aspects to a sexual assessment that could be explored. But again, first off is kind of finding out how interested the person is and talk about it, not forcing. We wouldn't want to get on a rampage and say, okay, this is really important, and we need to ask everybody a lot of questions. That would be as bad as not asking anything.
right. Well, we work with everybody individually, right?
Exactly. Yeah.
Yeah. Um, so you have some wonderful case studies here. Is it okay if we jump into those?
That would be fine. Let me figure out and remember how to turn on my camera here so I can uh share the, whoops, that's not me, is it? I gotta show uh that's the background. I'm not showing up on it, but that doesn't matter because I'm gonna just share my screen anyway. Let me see. Screen, I think I got it right here. Can you see? Nope, that's not what I wanted to share. Hang on. I'm gonna stop share so I can find the right one. I go to, okay, how about this? I think this will work. Share. Okay, can you see?
I can. I see your screen. Can you click on the case? Can you click
Yeah,
on,
slideshow
there you go.
from. from current slide. How about that? There we go. So let me move my picture of us in this somewhere so I can see it. Move this up here. So this is important because this was a nurse who
wait,
had,
I'm sorry to interrupt you.
yeah, can you see it?
I see the, it says give subtitles a try.
Oh, guess you're not looking at the same thing I'm looking at. Hold on. I have two screens. So,
I see that one. Critical conversations about asking about sex and sexuality.
yeah. And you don't see the whole slide?
I do see the slide.
Hmm.
I mean, I can see the other part of your screen too, which is fine. Are you able to make, yep, I see that. Okay.
No,
Pathway.
that's the summary slide I wanted to show. So let me, I'll try one more time. Technology is not my forte. So let me see one more time. How about this one? Does this show? Do you see this?
Yay. Okay. Now I'm going to share screen. Ready?
Okay, yeah, yeah,
Okay, here we go. Okay, here we go.
okay.
Case example number 1.
So this was a nurse professor at the University of Oklahoma Health Sciences Center. And she shared this example in the HFA companion book. And we can just read this here. A week before Sally, at the age of 37, died. For 3 years, she'd been under treatment for a malignant brain tumor. And when this nurse professor initiated the conversation about sexuality and intimacy, her immediate reaction was, I think about it sometimes. I miss it. I don't know where it went. She added that she was dissatisfied with her sex life, and when asked where she would rank her sexual needs at this point in her life, she said towards the top. And she asked to be more specific, she said my favorite foods and then sex were her priorities. So regarding her relationship with her significant other, she said, we've grown apart. It's very sad. She said that the change in their relationship occurred a year after her cancer diagnosis. And at that time, they thought about counseling, but they didn't think they were really ready for that big a step. And then she goes on to say, we were wrong. When asked about what she wanted from her healthcare professional, she said, don't just focus on my body, but help with the relationship. So it's just a very sad example of why I think this topic is so critical. Even though she, had not been intimate or close with her partner in over a year and a week from her death, that was still the priority. I mean, that says it all there, I think.
Mhm. Yeah, I think this is such an important thing. And it's interesting because I feel like in hospice, we talk a lot about food. And it's interesting that she said, her favorite foods and then sex.
Yeah,
This is a really, like you said, this is a topic I think we shy away from, and it's really important to people.
yeah, yeah. This next one is I like as well, if I can advance the slide. Because again, it's a younger couple, and not that all my examples are not younger couples, so let me put that there. But here's one. This is after several years of cancer treatment, Alexandra chose hospice. Her pain and nausea prevented her from wanting sex, yet she craves her partner Blake's loving touch despite the tenderness she feels all over her body. Most of the time, the pain is tolerable, but one afternoon it's too much, and so she swats Blake's hand off her shoulder that he's massaging, and feeling angered by her own body, but wanting to protect Blake from her own fear of decline, which patients do so much of. They protect their loved ones. Alexandra redirects her conversation and acts like nothing happened. And though no words were shared, Blake feels so responsible for her pain. Afraid of hurting her again, he stops touching Alexandra quite so often, and then not at all. So this is an example where, the hospice staff that would be involved might notice it and bring it up to the social worker at the team meeting. That would be a classic conversation that would come up in a team meeting. And there's different models and different ways that we can approach this. And again, I highly recommend Hospice Foundation of America's companion book for this topic on intimacy and sexuality at end of life, because it spells out these models, but there's one called the explicit model, EXPLISSIT. So kind of using that as an example, like how do you begin these conversations is often what people say, even if we bring up this topic. But the EX would stand for extend permission. You'd extend permission in this case by bringing up, probably in this case, it might be the social worker or the nurse, whoever felt closest and most comfortable, to bring up the topic by maybe saying to the patient next time they're out, one of them would say, how close they seem to be overall. And then raise the topic of maybe mentioning that I remember Blake used to be more physically affectionate and he doesn't seem to anymore. Is that upsetting to you? Something like that to kind of start the conversation and find out what Alexandra says about it. Limited information, the explicit has an LI in it. So the limited information would be, we would offer with some limitations. We don't want to overwhelm staff and patients, but we could explain that a lot of hospice patients do experience a change in their intimacy and sexuality, sexual activity, and what concerns do you have about that? Now we know from this case example, she was not interested in sex anymore, but yes, she did miss the touch. So if she's missing that physical touch and she brings that up in the conversation with the nurse or the social worker that initiates this conversation, we could ask Alexandra, would you like me to talk to Blake separate from you? Would you like to have a couples conversation together? I mean, we'd bring up the options and see where things go with that. In the explicit model, again, using that to kind of guide a clinician through how to step through this. The last T in that is therapy, but in this case, intensive therapy. But in this case, I don't think intensive therapy is necessary. Most of the time with these types of situations, I think what's missing is the communication, and really bringing it up, starting that communication, modeling the comfort level in doing it, working with the patient to see what would be most comfortable to that person would be the way to kind of address it, and might be able to make a significant change in this woman's life for the latter part of her life. So that's just kind of illustrates how we would handle it.
Yeah, what's so interesting, going back to the beginning of this episode when we talked about similarities and talking about death and sex, bringing together Alexandra and Blake to have, often the social worker would facilitate these kind of conversations. This reminds me of when I would sometimes have conversations where either the patient was dying and was trying to protect the family member or vice versa. And it was very similar, right? The social worker would have to kind of facilitate a conversation. Hey, you're both alone and you're isolated in your pain around the patient dying, but we're not coming together.
Right, exactly. Because most likely they miss that and they want that, but they don't know how to go about it. And we need to facilitate. And that's what it is facilitating. It's just helping it happen. So let's see what I have another example here. In this case, this is an interesting case because it's a true story. Sharon's husband, John, had a debilitating stroke. She'd been his caregiver ever since. As the primary caregiver, she misses cuddling, hand-holding, as well as the sexual relationship they used to have. After running into an old boyfriend from high school long ago, Sharon began seeing that person and started an affair. And of course, Sharon struggled with guilt and prayed that John would be released from his suffering and die in his sleep. But a few months later, she made an appointment with the grief counselor because she was devastated that her lover died of a heart attack. And she felt there was no one else she could talk to about it. So, it just probably what had happened in this scenario, which really was a true story, that I got from one of the grief counselors at our Center for Grief and Loss. But I'll bet you money that nobody had done any sexual assessment with the caregiver about, boy, you're doing all this hands-on caregiving, your relationship looks like it has totally changed. What are some of the things I'm guessing that some of the intimacy you shared before and the relationship with your husband is so totally different, asking those questions. I bet nobody ever did any of that. And another question might be, are there any countertransference issues for you? I think there's a lot of assumptions in our society, maybe I'm guessing wrong, but that makes more sense if we'd seen that Sharon had the stroke and John ran into his old high school flame and started an affair. There's this assumption that men are the ones that have this, but in this case, it was the woman who desperately missed this and ended up feeling terribly guilty and had nowhere to kind of go with that. Where she felt safe, she couldn't talk about the devastation she had when her lover died because that's a disenfranchised grief. Nobody even knew that she had a lover. So she has no support whatsoever other than to come find a grief counselor she'd never met before. So it's a different angle on that, but still clearly conveys some of the challenges with end of life care.
Absolutely. Yeah. No, thank you for sharing that one. I think that was a really, really important one, and I do agree. I think that you're right. I think many of us have a bias of like, oh, men do that, or, versus this, we often bring these biases in, right?
Right, right. And actually this brings another bias in this scenario. Joe's a 71-year-old African-American male with terminal cancer diagnosis and heart failure, recently admitted into hospice care. And he asks the doctor about a prescription for Viagra and explains that his sex life with his spouse has always been an important aspect of their relationship. The patient exhibits no cognitive impairment and minimal functional concerns except for that persistent fatigue. So cognitive is important because he knows what he's asking for, and he understands the ramifications of that physically. He's aware of the risks related to his medication request, including the potential for death. And so, the point with this one is it can bring some of those ethical kind of quandaries with staff possibly who think, why put yourself in that position that could jeopardize your life possibly? But on the other hand, we need to be okay with clients making their own decisions. So just being aware of some of that countertransference possibilities. Would you feel the same if this was your spouse? Would you feel differently if it was your spouse? All those kinds of questions. And again, there's different models that you can use to kind of know how to you handle a situation like this. And so when I did the training in hospice, there's a model called ALARM, ALARM, that's usually used. Part of the criticism with it is it's really focused on just sexuality and not intimacy, but it kind of fits in this case. Using that alarm model and trying to, this was a hospice case of ours, activity, A for activity, asking what their sexual activity was prior to the illness, confirming that, despite their illness, their desire, the libido is still clearly important to them. That's the L in alarm. And then, obviously they found a lot of satisfaction out of, an arousal that's the A for arousal. So kind of stepping through the model helps clinicians kind of have a sense of how to approach a situation like this.
Mhm. And you bring up something, I actually sat on our ethic committee at the Visiting Nurse Hospice, and there's a lot of ethics in healthcare, and particularly, I think, at end of life. I think there's a lot of ethical stuff really comes up, and that's really connected to like what you're saying of our own biases, right?
Yeah. Yep. Yeah. I mean, this will get us off track a bit, but the point being with MAID now in 11 states in our country, it brings up the issue of, how people feel individually if it's a state that supports, medical assistance in dying. I remember I spoke years ago out in, I guess it was Seattle. I always get Oregon and Washington mixed up, but it was out west, and it was a state that had physicians assisted suicide back then. And I was very interested in how because our hospice, how would you handle that? And then they explained to me that each hospice has to make their own decision, whether they're comfortable in, supporting that or not. So I think that's a ethical issue coming as well these days that needs to be talked about more.
Yeah. Yeah. Oregon, I think, was the first one. I hear you.
Okay. That it
Yeah.
was hard and yeah. And so this one other example, for Lydia, sex and marriage is both a gift and a responsibility of intimate connection. She and her husband, George, had a fulfilling sexual life prior to his cancer diagnosis, but now he's quite ill and he still seeks sex, but Lydia's scared that sex might cause him physical pain. And she's torn between the value that they both place on sexual intimacy and her lack of interest in sex due to how exhausted she feels after years of caregiving. And yet my guess would be in this case, unless they're not talking about it, even though it's important to him and she's dedicated to her. So all these dynamics you see are going on, but it's unlikely that they would bring them up to, even though the social worker might be doing a quote comprehensive psychosocial assessment. If she didn't ask those questions, they wouldn't volunteer this information. And yet there's a lot going on here. So how would we even be aware of what's going on, much less figure out how to support them? So again, using the model, if you use this explicit model, saying something like, often spouses worry they might cause added pain or discomfort. Do you think this is a concern of yours? Is this something that worries you? I would ask Lydia, that kind of thing, or ask the husband that, see what he's thinking about. So it's just kind of figuring out where people are, but bringing it up. I think there's a lot of information that will come out of this type of situation if we ask the right questions.
Mhm. Yeah, yeah. And I think, opening it up really just helps people. It could just be that Lydia wanted to even just talk about it and isn't even looking to fix it, right?
Yep, yeah,
You
yeah.
know,
Because she cares about her husband and he cares about that. So how do you, like a lot of things in relationships, there's compromise somewhere. We got to figure it out, but you got to talk about it in order to figure out a compromise.
Mhm. Yeah.
So, yeah, I think that's the last example, but I had really what I think is important to these pieces, in healthcare provider training, improving communication skills, reorganizing the patient environment. We didn't talk about that, but a classic teachable moment and opportunity is oftentimes when the nurse has to bring up the possibility that the patient may be upstairs in their own bed living with their wife for 40 years, and suddenly the nurse is saying, well, how about we put a hospital bed downstairs on the first floor? But what does the nurse often do? She'll look in the living room and say, look, you've got a nice big living room. We could put the commode chair in the corner. Not at all thinking about privacy and intimacy, but being on display in the living room. And oftentimes these days, houses don't even have doors to the living room. They're open. So is there some way in that patient environment to create a space that can be private, or to provide a way that the wife's bed can be right next to the patient hospital bed? I mean, what ways so they can hold hands? I mean, it's taking that opportunity that seems like a real challenging situation and having conversations about it rather than just assuming they'll go along with it. So oftentimes patients will decline a hospital bed, but the nurse doesn't ask why, and then they can't go any further. But it's because they still want to be with their spouse, and that goes right past the nurse's realization, I think. So and by clinical people bringing up the conversation, the professionals can explore and share ways to kind of address the symptoms, because we haven't talked about that either. But of course there's many different symptoms related to the illness that are going to affect people's ability to even have sexual activity or anything. But there's ways to adapt that. There's time of day, it's positions in the bed. There's all kinds of things to explore if they're talking about it. But if they're not even talking about it, then none of those potential solutions can be considered.
These are really important parts to bring up. And, certainly here in New York where space is limited, you are absolutely right. I, can't tell you how many times we had the hospital bed was right in the middle.
Yeah.
So you're right. So these are all really, really important pieces. Okay.
I don't know why you're looking at the Coliseum, I think, if you see me, because I don't know why I'm looking for one other thing I was hoping to share. Let me see if I can pull it up here.
Okay, I turned off the video for a
I
second.
know, that's fine. But see if you can see this. But I don't think you can. I don't know what happened to it. Well, I had one other slide, but this is hard to figure out how to show it. Yeah, so never mind. I'll just tell you what was on it that I thought was good. It just, things to consider when addressing sexuality in palliative care. It's to kind of wrap things up. It's sexuality and intimacy should be a routine part of the palliative care assessment is part of my point. And then, we have to really keep in mind working within the family's value system, starting where the clients are with all that. But I think if the practitioner is comfortable at, being straightforward and being open and conveying that warmth and empathy, genuineness, and then yet being kind of casual about it and just conveying their willingness to talk about this topic, then I think they'd be pleasantly surprised to find that the patients want to talk about it. So I think it's an important aspect to really keep in mind, using the open-ended questions, providing education, empowering the patients and families to bring that up, just even introduce it in the first assessment to say, I am open to talking about this at any point while we're working together. So just don't hesitate to let me know if the questions come up along the way. Even just planting that seed at the beginning goes a long way, I think.
Absolutely, absolutely. And I was going to add that when we were talking about earlier about having the conversation, what I did often happen in hospice is I might bring something up and the person would hesitate, or we wouldn't have it in that session, but I would come back the week later or 2 weeks later, and then the person would feel comfortable. So you're what would we call it? Trust building or bonding with the family and the patient, right?
Exactly.
Yeah. Well, I wanted to just mention one other thing that I thought was really helpful. In one of the models, it's the BETTER model, BETTR, which was developed for cancer patients, but applies to other illnesses. In bereavement, you might want to validate the secondary loss of intimacy and sexuality, as well as discuss how varied manifestations of grief may affect intimate relationships and sexuality. I thought that was really important.
I think, yeah, we didn't talk much about bereavement. And again, that's another area where there's a lot of room for improvement, let's say that way. It just, I think we overlook the fact that loss of physical touch, loss of an intimate relationship, if people have lost a spouse, people have lost a child, it behooves us to bring it up and explore with them, because otherwise it's not going to happen. And the few conversations I've had have been with people that I've already had a close relationship with, clinically, and because I've got that good relationship with them, then they'll bring it up. But it does get tricky in groups, for example, if it's a closed group and you're working with people for several sessions. From what I understand, talking with my bereavement counselor colleagues, the conversations go a lot better if you have people all of the same sex. If it's people of mixed sex, you've got men and women that have lost a spouse, for example, it's a bit more awkward because people are in such different places about the whole thing. Somehow it just feels safer when it's all women. That's what I've learned so far in the conversations I've had with people.
That's a great point. No, thank you. I can see that. That's a really good point. And I want to add, though, I'm going to add to my assessments, and I'm going to add to the ones I do and to the trainings I do for my clinicians to add this as part of our assessment, because I'm sad to say we never asked about this in
Right.
our, yeah. So this
Exactly.
important thing, like you said, to open up in bereavement also.
Yep. Yes, very much so. So just, and the better speaks to B is bringing up the topic. E is explaining that intimacy and sexuality will affect the quality of life. And you might say that you don't have all the answers, but want to convey that you're, open to discussing it. The two T's, one is telling the patient or client that you're willing to explore resources to address and discuss it. When I did a handout for the staff and talked about resources, I also did research in our area, in our geographical area, who are the sex therapists. So I have those names and information that I handed out to them as well, so that we need to know who are the resources, because I'm not a sex therapist. So if they bring up things that are an issue that need to be worked on, then I need to know what those resources are. So, telling them that you're willing to explore those resources, timing, you recognize that it may not be the right time right now, but they can bring it up again. The E is educate on any, treatment or disease that might impact the sexual relationships. And E, when it comes to bereavement, when you're talking people who have lost a spouse after they've had the spouse for 40 or 50 years, and they tell you that they also want to date. I mean, there was a man that I worked with for a year and a half, and he was very intentional. He was deeply grieving his wife, but he also was online looking for a partner. He was happy being married, and he desperately wanted to find another person. He knew what he was looking for. But, part of my point to him is, in the 50, 60 years he'd been married, things have changed now. There's a lot more issues with sexually transmitted diseases, and nobody who's been married 50 years thinks about that. So, cautioning people about information like that is important to kind of mention as well. So educating them about those kind of things. And then the R for better, that better model is recording. You're documenting the gist of your conversation, not all the nitty gritty details, but at least the fact that even the fact that you use the better model to address their concerns in this area would be good to do.
No, that one I thought I did want to bring that. Yes, that's wonderful because bereavement is, of course, an important piece. The last thing before we wrap up, and now I can't find the slide, but I think you had a slide for populations for further understanding.
Oh, good point. Yes. Because I said in the beginning, this is kind of a 101. It was a beginning conversation, but I certainly don't want to anyone who is maybe passionate about LGBTQ issues or the elderly or something like that. We have to recognize that there's many more areas that we didn't even begin to touch on today, but I didn't feel that we could adequately address conceptually just the general concepts without starting with the basics. So I didn't I think there's a lot more areas to my point with in bringing this up with staff was saying that we need to start somewhere. And after, I would encourage people to kind of incorporate into their practice some of these questions in their assessments and see where that brings you in terms of your connections and relationships with patients and families. And then let's come back again and talk further about how that's going. And then we can get into a little more depth, some of the other areas. I mean, take an elderly couple. It is wrong for us to assume that because they've been married for 60 or 70 years that they don't, and they're now in their 80s, that they don't have a sex life. We can't assume that that's the case and therefore not bring it up. So I was looking forward to kind of learning from them as well. What are you finding as you're bringing up this topic, and what are some of the areas that that we haven't addressed yet that we need to talk more about? So that's my point with this. This is the beginning conversation.
And really important. I do think, sex certainly isn't a new topic, but really doing this assessment at end of life is kind of new, and it's important. It's important that, hospice clinicians and in bereavement as well, we're really opening up these topics. So you're right. We're learning. I always say I'm always learning from my clients and, my patients and families.
Exactly. Yeah.
Well, before we wrap up, is there any last thing you want to add? I mean, this has been wonderful, really. This is really fantastic.
I guess I just want to encourage people to consider. I mean, maybe there's a few people out there that are addressing this well and passionate about it, but what are we missing? Thinking about where can they improve their practice? Is this an area that they need to expand on, and in what way? I just encourage people to reflect for themselves where they are personally with it, and how that might influence where they are professionally with it. I guess that's a key piece.
Mhm. Yeah. Yeah. Always looking to expand our clinical practice, our scope of practice. And you're right. This is, as we had talked about, we have to also examine our comfortability.
Mhm.
Yeah.
Exactly.
Well, thank you so much. I really appreciate your time. This has been really, really wonderful. I think helpful. I think it's a really important topic. So I appreciate your expertise.
I'm happy to be here. Thank you so much for the invitation.
So thank you so much, and thank you for everybody who's listening to Thanatology Themes. Thank you again, Patti.
Take care.